to everybody, the advice is pretty much the same for all people. So the critical things that people need to do is really look out for any unusual rash, any sudden onset of fever or swelling in lymph nodes, and of course, just really be conscious of your own social networks. If you hear from a former or previous or current partner, whether it's a social partner or somebody that you've had a sexual relationship with, that they're either unwell or maybe suspected of being exposed to monkeypox, certainly take extra care and seek health advice. So for the moment, it's really thinking through how to be alert to the symptoms and how to react to them swiftly should you have any concerns. For the community that's particularly affected in the current outbreak, particularly in Europe, where we're seeing most of the cases so far, the vast majority of people from this community are well connected to health services, including sexual health services, and understand the basics around STI screening and control. And so again, we encourage that very positive health-seeking behavior, which may in fact have contributed to the early identification of the current outbreak. I should say, the messaging is needs to be quite nuanced, and I think that we shouldn't shy away from talking about things like, reminding people that it's still useful to think about condoms, for example, for protecting against unintended pregnancies and sexually transmitted infections. But for monkeypox, condoms will not provide a layer of protection that's additional, given the fact that it's close body contact or personal contact that is the main risk factor. So again, really thinking through about being alert to the symptoms. If you have some concerns about about STIs and unintended pregnancy, condoms are a great option. But really, it's about thinking about understanding the risks and reaching out to your local and national health authorities and various community organizations who are increasingly putting out advice and are very active on social media. So I think there's a lot of information out there now, which is good information, and it's been localized to national context, including various helpline numbers, etc.
So that's a lot of information. It's not simple. There's not a simple answer. And I think you made a good point there, Andy, when you said people aren't going to get all the answers from this. Seek out other sources of information, especially if you're in a community that's particularly affected, whether you're in a country where the disease has existed before or in a country where it's newly affected. If it's circulating in your particular community, there's very likely to be information. It's one of the reasons we're working closely with countries to encourage them to share information with their populations, and especially those who are most affected, and especially if somebody themselves has monkeypox, to ensure their family members and their social networks are aware as well. So there's very specific ways to pass the information as well. And I know it's hard to absorb what we're answering in this Q&A. But Andy, you did answer a couple of questions already. So Mars Bakachina was asking, what's the transmission method? And you explained that it's through skin-to-skin contact with lesions, in particular from someone who already has it. And Sushmita Devi Mayanglambam was asking, what are the symptoms and how does it transmit? So you've covered that as well. We have one person asking, so Chris Britton Rehman, and I think this is a question for you, Rosamund. If we should not worry, why is this starting the way COVID started? So I guess they're saying in a way it started slow, and COVID started slow, but you need to worry about it a lot. So why are we saying not to worry about this one? Whereas COVID, over time, we realized that you needed to worry about it more and more. It started small and got big. Why are we saying that this one is different groups of people? Over to you, Rosamund.
Yeah, Nikki, you've really just said it really clearly there, different risks for different groups of people. So we have as of last Friday, information that was published online in our disease outbreak news, which you can find on the WHO website. The cases are already in 23 countries. So this is different from COVID in many ways. It's different from COVID because the disease is different. It's different because the virus is different. It's different because the way this particular infection transmits is different. However, it's also different from COVID because it's gone to so many countries at once from just 10 days, 2 weeks ago, and now we're seeing cases in 23 countries. Again, you might ask, well, there's not that many cases. There's only 250 confirmed cases and over 100 suspected cases being investigated. And this does not include the numbers from the weekend. So we're looking at slightly higher numbers than that. But at the same time, well, these are not very big numbers. That's true. But it's very unusual, atypical for us to see this particular disease in this many countries at once. We've only had a few cases that have been detected or reported by national health authorities over the last 5 years. We've had fewer than 10 cases. So now we're seeing a very different picture. So that is why we are, as a health organization, we're concerned, because countries that are now seeing these cases, they need guidance, they need support, because they have not seen this particular disease before. We only have a few countries that have seen this particular infection before. So for that reason, it's concerning. However, from a public health perspective, we have to differentiate between the risk to the general public. As Andy already described, this is a disease, an infection that transmits primarily through very close contact, primarily through face-to-face, skin-to-skin, mouth-to-skin contact. It can transmit between people who are engaged in intimate sexual activities, or it could also simply be transmitted by someone who's touching the skin of someone else. That could be someone in the family of the person who has the infection. So whereas it's not something that we think is going to spread very rapidly in the general population, we are concerned that those who didn't know what it was that they had, this rash, they didn't know what it was. Now people are becoming more aware and beginning to understand they can still protect other people. They can protect themselves. They can protect other people by stopping the spread. It's really important to stop the spread because this virus can transmit by close contact. So if people are having this very close contact through skin-to-skin contact, through sexual activities or other things, then anyone who has that type of closeness may be at risk from somebody who already has the infection. What we would not like to see is that this continues to spill over into other friends, family members, and the general population. It's still possible to stop this outbreak before it gets larger, and this is what WHO would like to support countries to do.
So we have some questions specifically on how WHO supports countries, but I first want to touch on vaccination because there are a lot of questions around that too. So I'll ask several of the questions, but I think you can cluster your answer, and I think this one stays with you, Dr. Lewis. So this is from Angela D. What is the difference in the risk of infection of those who are over 50 years old in the US who have had the smallpox vaccine versus those people who have been too young to receive it? So that's one on vaccines. Hang on here. Masoud Jogetsai is asking WHO, the vaccines, arrange for antiviral agents, so treatments and smallpox vaccines for countries who may need it. So just touch on the vaccination part of that one. And let me see if there's anyone else. One last one here. Tirankari Mani Tripathi is asking what kind of vaccine are available for the prevention of monkeypox. So over to you on the big vaccine question. I know that one's complicated too.
Well, there's quite a lot that you've packed in those few questions. And thank you, Angela, and our other participants here today for those questions. You've raised a really good point, which needs to be mentioned, and that's that this particular virus is related to the virus that did cause smallpox. And you may be aware that smallpox was eradicated worldwide it was declared eradicated in 1980. So there have been no cases since late 1978 of smallpox. So why is that important today? Because as you point out, up until 1980, many countries and most people around the world were immunized against smallpox. And this was one of the strategies that helped us to eradicate this, really what was a horrible, it was quite a terrible illness and very infectious. And now this particular virus we have now is a family member. It's not the same virus. It's not as infectious. It does not cause a severe disease, but it is a member of the same family. So we have a situation where for the last 40 years, people may not have had any immune protection through vaccination, and certainly not through exposure, because these viruses have not really been around for the last while, except in a few countries where they're considered what we call endemic, where they may live in the animal population and then come into the human population. That's a different situation from what we're seeing right now. So you're right to ask if people over the age of 50 who still have a scar from their smallpox vaccine immunization may be protected. And the answer is yes, they may be protected. We may be protected, but we don't know for sure. 50 years is a long time to hold a vaccine, and we don't really know for sure if most people will have some immunity over the age of 50. It's probable that some do. So that may be part of the explanation why we have begun to see this new disease called monkeypox appearing in certain countries and now appearing around the world and traveling fairly quickly through close physical contact, is precisely because we don't have immunity against pox viruses, these orthopox viruses, at the moment. So why do we still have vaccines then? If we have not been vaccinating against smallpox, for example, or other orthopox viruses, why do we still have vaccines, and how could we use them? Once smallpox was eradicated, the governments of the world, through the World Health Assembly, agreed that this was an unprecedented act. The fact of smallpox that it was eradicated was a huge public health achievement, but it was also unprecedented. It had never been done before. It was the first human disease ever to be eradicated. So the agreement was that certain stocks of vaccines would be maintained, and the WHO would be tasked with overseeing research to continue developing newer and safer vaccines and treatments. So this is what has happened. And over the last 30 to 40 years, various parties, researchers, academic institutions, government institutions have continued some elements of research which have contributed to preparing the world with some newer vaccines. However, these are new products. One of them is actually already approved for the prevention of monkeypox, but they are new products, and therefore they are not yet really widely available on a global scale. And this is true for the antiviral agents. There are a couple of antiviral therapeutics which have been approved for the treatment of monkeypox. But again, this was the result of 20, 30 years of research. And so these products are just coming online now. So at the moment, we're supporting countries by providing information on what is available, what it could be used for. So we do have a new monkeypox vaccine, but at the same time, it's new and it's not in large-scale production yet. And we do have some smallpox vaccines, which have been approved for smallpox, that are not the same as the ones using the smallpox eradication era, but they are newer and safer than that particular generation of vaccines from 50 years ago. But at the same time, they are also limited in national vaccine reserves. And so WHO is working with the countries that have some of these products to bring us all together around the same table and talk about how we can support countries to access products, keeping in mind that for the time being, supply is limited. And for the time being, the recommendations are that those who may be exposed to someone who has monkeypox, in other words, a contact who's at high risk, may be offered vaccine where it's available. So right now, immunization guidance is really focused on people who are at risk because of actually being a contact of someone who has monkeypox. So that could be an intimate contact, it could be a family contact, it could be a health worker who didn't have the appropriate protection at the time of seeing the patient and making a diagnosis. And so there are a few groups of people who may be at higher risk, who may be offered vaccines in certain circumstances where they are available. And we are all working hard to make these vaccines more available in the coming weeks and months.
So Dr. Lewis, I'm going to summarize and let me know if it's accurate. So the initial question was, if you are somebody who has received a smallpox vaccine, and that's usually people who are over 40 or 50 years old when smallpox vaccines were still being offered, if you've received that vaccine, it may protect you. The antibodies you have in your system may protect you against monkeypox, but we're not sure because immunity wanes, as we've learned around COVID vaccines, and because we haven't really tested it, I suppose. We don't have data to find out if somebody who has the smallpox vaccine is safe against monkeypox, or safer. So that's one. Then there are more modern smallpox vaccines, or there is one that can be used for monkeypox, not widely available. And did you say there's also a specific vaccine developed for monkeypox, or it's more a smallpox vaccine approved for use in monkeypox?
Yes, it was developed for smallpox, as are some of the others. But there is this one product which the manufacturer did additional studies for and sought licensing approval to have that also approved for monkeypox, which is the case in some places.
Okay, and as you specified as well, not widely available because the world didn't think we needed smallpox vaccines or even many monkeypox vaccines available. And for now, even where there is some availability, it's used for very specific people who are at the most risk and therefore need the most protection. So a healthcare worker or the close contacts. I have a question for you, Andy. This is from Chad M. Morgan JP. I'm concerned that the narrative still centers around men who have sex with men. This mirrors the early days of HIV. Why not focus broadly and not on just a specific population? So why are we trying to have both things at once, Andy? Why are we saying this isn't about men who have sex with men, it's about other populations, but then again, here's some guidance for men who have sex with men? Can you just explain that context?
Yeah, but it's a great question, and we think hard about this, and we speak regularly with community leaders for advice on how best to tackle this for exactly the reasons that you've raised. So thank you so much for raising those issues. We're very fortunate that we have real leaders in the field of LGBT health who work with us through our strategic, technical and advisory committee for HIV, hepatitis and STIs, but also for other areas, including sexual and reproductive health and rights and gender. And they're helping to guide us. And it's really, it's challenging, to calibrate this, to balance the risk messaging and not unintentionally contributing to stigma. So I think it's really clear to us that, this is not a disease. First of all, it is endemic to West Africa, where we know a lot about how the disease is transmitted there, where we don't have the phenomenon that we're looking at the moment, which, as Rosamund has explained, is linked to social events. So we've had a number of possible amplifier events in a number of European countries where people have traveled to parties or events, and then sadly there has been a result of some onward transmission in those scenarios. And that could have happened to any group of people. Gay and bisexual men are not the only people who gather in close social events and circumstances, but by any means. And so I think in many ways it's unfortunate that we're having to make these calibrated and balanced decisions about how we get this messaging right, exactly because of the reasons that you've said. But as you say, we have a lot of lessons learned from the early days of HIV and working with communities, and we need to continue to do that. So we will continue to have targeted conversations with the groups that are currently, perhaps, experiencing the outbreak more than others. But as I said earlier as well, and Rosamund has also underlined this, the prevention messages are the same. It's largely connected to close skin-on-skin contact, kissing, touching, mouth-to-skin contact, etc. And there is no change in the message there. So, there is no specific transmission route that we need to be worried about. It really is connected to the fact there have been a couple of events that have perhaps amplified the current outbreak. And I know, perhaps if I may add another point, we've been having conversations with the International Lesbian Gay Association, given that it's Pride Month coming up, and they're talking to a lot of the organizers of official Pride events. This question has come up a few times, is it safe to attend these events? And from our point of view, I think we would like to send a message that it's important that people who want to go out and celebrate gay pride, LGBTQ plus pride, to continue to go and plan to do so. Most of these events the official events are outdoors, they're family friendly. We don't see any real reason to be concerned about enhanced likelihood of transmission in those contexts, because the parties that we've been looking into have perhaps been more in closed spaces, in nightclubs, etc. So I think that really it's trying to get that balance right. Continue to have the conversation for and with the LGBTQ community, to continue to learn from the lessons from past epidemics, and to continue to really try and provide as much information in a measured, calibrated fashion, recognizing that, you know, we have to get that balance right between providing information and not unnecessarily raising fear amongst all groups, including communities of gay and bisexual men.
So I think by doing something like this, and the other work we're doing, our colleagues that work in risk communication and community engagement, for example, and our colleagues in our regional offices, the idea is to raise awareness amongst everyone, right, but not everyone is at the same level of risk. So I have a couple of questions related to that as well. So we have Martin Still, who says, I get the impression that this disease is milder at the moment. And I think what's understood in that question is, why do we need to be worried it's a mild disease? So I'll ask you to take that one in a second, Rosamund. And then there's this other one that's a little bit cryptic, but I still think interesting. It's from Twitter. I didn't manage to get the name in time, but the question is, how scared should I be on a scale of 1 to 10? So that's related as well. I don't think we should be giving numbers. WHO doesn't use scare numbers. But we do talk about how high we think the risk of spread is. If you could just talk a little bit about, why are we doing this? We did one last week. We did one today. Our colleagues who work in EpiWin did a webinar. We issued Disease Outbreak News, which is a public document. And yet, if you look at the size of the globe, we've got a few hundred cases of a disease that should be self-limiting most of the time, meaning you get symptoms, they go away even without treatment. So why are we concerned? Aside from the fact that we are seeing this disease in new countries, you touched on that already, but why is this disease of concern at all?
Indeed. So thank you, Martin, for the question. And whether this is being milder at the moment is something that we ask ourselves as well. Now, I did see someone in the chat saying there's a lot we don't know, and therefore, we question what we're actually saying. But for one thing, I can say that WHO has been monitoring this infection and this particular virus since it was first discovered in 1958, and since the first child was found, the first human being was found to have this virus in 1970. And so since that time, it has been learned that there are two clades of the virus, one in the Central African region called the Congo Basin clade, and one in the West Africa region called the West African clade. And historically, over monitoring the disease for 50 years, we have seen that the West Africa clade seems to cause less severe illness overall, fewer deaths in the African context. Remember, deaths are not common here, but there are fewer in the African context than in the the Central African clade. And so the question now is this virus even causing even less severe disease? And it's, again, like many things, it's hard to know the answer when we're seeing something that is very new manifestation. It's manifesting in a different population, in different countries, in different groups of people. And so we are all learning at the same time that whether this is or is not similar to the disease that we are familiar with in the forested regions of Central and West Africa. Two things that we can mention that may help us discern this. One is that after the eradication of smallpox, we talked about immunization and how people are no longer being immunized. So the first people to really be reported as having monkeypox were children, because they were immunized right from the youngest age. And then a year goes by, 2 years go by, 3 years go by, 4 years go by. So those children under 5 were the ones who were not immunized, and then children under 10, and then and now it's people under 40. So in the early days of study around monkeypox, most of the people who had monkeypox were in fact children. There were some older folks as well, and people, again, primarily men, who would go into the forest and they would hunt in their traditional hunting grounds, and they would come and find rodents and some non-human primates, monkeys, and they would prepare them for meals, but the preparation may have exposed them to the virus, or even not fully cooking the meat may have exposed them to the virus. But who were the ones who were really at risk at that time were still the children. because children have a less developed immune system, and so they may have a stronger reaction to the virus itself, and they may have more severe illness. What we're seeing since then is the virus is moving into older populations, even in the endemic setting. And now we're seeing the virus primarily in, strong, healthy men in their 30s, not exclusively, but largely. And so this is a population that in any case has greater ease in fending off an infectious disease, perhaps, than young children. So are we really seeing something that's milder, or are we really seeing something that's milder because right now it's transmitting in a group of people who are by and large otherwise healthy, so and who have very positive health-seeking behavior, who when they see something, they would go and look for help and consult their healthcare provider and get treatment early, and try and get a diagnosis early, which is now becoming possible because now this issue is being recognized worldwide. And so really what we don't want to happen is that it would now then move into groups of people who have a less robust immune system, either because they're younger or because they have other conditions or because they have other infections that would put them at risk of either contracting the infection more easily or having more severe disease. So, we really want to try and stop the further spread of this. So how scared should I be is obviously we all want to be able to answer that question. Am I scared about this? No, it's not necessary to be scared about it. I don't think we should be scared collectively. We have two concerns. One is the continuing spread from a previously undetected, undiagnosed infection. So now, we all need to catch up, and health workers, doctors, nurses, health authorities, governments need to realize that this is something they need to work on. Get test kits out there, train health workers, raise awareness so that the cases that are occurring can be detected quickly, and so that transmission and further spread can be stopped. That's the objective. If we all react quickly and we all work together, we will be able to stop this, and we will be able to stop it before it reaches more vulnerable people and before it establishes itself as a replacement for smallpox in the broader population. So that's why collectively we are concerned that it will replace smallpox, and we really don't want that to happen. And we still have an opportunity to stop the spread to make sure that doesn't happen. And then, of course, support the countries where monkeypox occurs anyway, in West and Central Africa. So to find out really what's happening, why has this global spread begun, and how can we support the countries who need to react where it is most common already anyway.
I'm glad you added that. And if people want to know what the burden of disease is in those affected countries, you can look at the disease outbreak news that was released on Sunday evening. Just search WHO, monkeypox, disease outbreak news, and you'll get the update from Sunday. And there's a list of the main countries affected in the African region and the number of cases they've reported, some since December, some for a year, and so on. And that's a really good point, that this disease matters no matter where it happens. I just wanted to come to you for one last point, Andy, and then I'll list the countries from where people have been watching us today. But Andy, why does stigma matter? The idea, if people get the wrong end of the stick away and they say, oh, this is a gay disease, or this only affects people who went to that particular event, or it only affects this type of people. Why is that a problem for outbreak response? Why is that not good for all of us? It stigmatizes that group of people, which is not good, but it also has a wider impact. Can you explain a little bit about that?
Sure. I mean, essentially, what we've learned from HIV, but also stigma is not linked to just communicable diseases. There is stigma, sadly, around a number of health issues, disabilities. And what can happen is, if stigma really kicks in, it will create a barrier for people reaching out and asking questions and seeking advice from health workers. So, for example, there might be I don't know, a heterosexual couple may have gone to a dance party, to a festival, and then, either one of them may have developed a rash. If they feel as though volunteering themselves to the services somehow identifies them as being part of a community of which they don't belong, they might hesitate before seeking advice and seeking services. And that's problematic. That's really problematic, as you say, not just for the community, which is being stigmatized, but for wider society. So I think we need to recognize that, you know, the risks are there, this is happening, and make sure that we're clear in the information about transmission. And as I said before, we're really creating that balance between presenting the facts as we find them and as cases are reported, so that we can act quickly to contain this. I think the communities in question at the moment outside of the endemic countries are really keen to be active in helping to contain this. And there's more sharing now on social media about experiences of having to go into isolation because people have been identified as potential contacts. And that in itself, we talked about fear, the other question. I think, you know, people understand, you know, through COVID, you know, what happens when there may be some fears about onward transmission. And the last thing any of us wants as individuals, I think, is to be forced into an isolation when we want to carry on our working and social lives. So I think all of those things coming together, as we've said before, we need to be measured. We need to really be careful with our messaging, and it's never okay to stigmatize any one community around any disease, including HIV. We've mentioned HIV a few times, but certainly with all diseases, including monkeypox.
Thanks, Andy.
Nika, can we just also say, well, we jump in there, one last thought. We are not stigmatizing Africa either. We work with our counterparts in Africa. We work with ministries of health. We work with the doctors who are on the ground. Doctors on the ground in Nigeria, for example, are also reporting that they're seeing more cases. This is concerning for the countries that deal with this on a day in, day out basis. And we are working with our counterparts and colleagues in these countries so that we work together on a global scale and at a local scale. And we're certainly not trying to stigmatize Africa, on quite the opposite. We work very closely with our colleagues in the affected countries, and we are all part of the solution as well.
Perhaps I can add to that as well, Rosamund. That's an absolutely important point. You know, we've convened one formal community conversation, and we've had several informal, and we've had communities from the endemic countries really offering advice to the communities in Europe that are now being affected, and really being very generous with their time and advice. And so, as Rosamund said, there is some shared responsibilities and opportunities here to really come together to overcome stigma, but also really get ahead of this outbreak. Sorry.
Thank you both. Thank you for joining us. So just quickly to go over the names of our experts again, you just heard Mr. Andy Seale, Strategic Advisor, Department of HIV, Hepatitis and Sexually Transmitted Infections Program at WHO, and Dr. Rosamund Lewis, Technical Lead for Monkeypox at WHO. Thank you both. And now I will list the countries from whence we had our questions and people who are listening in. And there's some very nice comments going by as well, thanking you for the information you've shared. So thanks so much for that. If we spoke too quickly, we're very sorry, and you can rewatch on these social media platforms as well. So people joined us from the US, Nepal, Malaysia, UK, Eswatini, Democratic Republic of the Congo, Ghana, Mexico, Burkina Faso, India, Portugal, Tunisia, Turkey, Iraq, Lebanon, Yemen, Argentina, Tanzania, Mauritius, Jordan, Sudan, Nigeria, Kenya, Zimbabwe, Chad, Switzerland, Brazil, Morocco, Iran, Pakistan, and I didn't mention a few other ones. This wasn't a complete list, but we just wanted to thank you so much for joining in. We're glad that this is useful for you, and we will continue doing these, continue asking us your questions, continue asking your community leaders and your ministries of health these questions so that you can get information out for other people as well. Thanks again for joining, and have a good rest of your day. Bye from WHO.
Bye-bye. Thank you.